job. I'm a full-time paramedic at Dodge Center, but I have worked all over the state and done a number of different things. I'm on the Ambulance Association board. I do some consulting and just lots of different things. So I've done flight, I've done fire, I've done just about all of that. So, but that doesn't mean anything. The only reason I'm here is because we were talking. Most of you guys know all this stuff already. How's the IV thing going?
It's progressing.
That's what you mentioned.
They're trying it in the field, and it's it's a skill.
Absolutely. So keep it up. Make sure that we were kind of just chatting a little bit again. We talked about it the other night. We're not just doing it because we can. It still needs to be clinically indicated, but get on out and get your stuff done, and you'll be good. And then he likes people practicing, so just keep doing that. And then when we add in IOs, same offer? Okay, perfect. Okay. Yeah, we'll go generously on the Versed. So you have your own training arm, so we can play with that at the end of the night if you guys want to do a little bit of that. I can coach, or you guys can just work with that on your own.
And no one's come down to poke me when I'm here every day.
That's right. So if you're at all concerned, that's probably a good first step, is just coming on somebody here that's going to be patient with you. Tonight, we're going to sit and chat a little bit about underwater basket weaving. No, we're not going to do that. So we're going to cover a little bit of stuff on airway. So we'll just do a real quick refresh on some airway anatomy and some of the tools that you can use to help with respiratory. We're going to talk a little bit about difficulty breathing versus distress versus impending arrest. Versus some other things. So we'll do about that. So between CPAP and PEEP and some other of those tools. And then because it actually has a pretty direct relationship to opioid overdoses or overdoses in general, we're going to talk a little bit about your Narcan stuff. So I have some handouts I want to cover with that as we wrap it up. I will have you out here before midnight this time, so we'll be good. You guys heard that we were here pretty much partying all night? No, we're not. I'm guessing we should be done.
Yeah, the liquor store still hasn't sent us over the bill.
They haven't sent the bill. It's because they're going to do it in payments probably. Okay. So no, we aren't going to do that. But running back through a couple of quick things, and I didn't even bother putting a PowerPoint. I'm going to mark a marker board a little bit. I won't mess with your artwork though, because I know Arts and Crafts Day was today. But it did. But I'm going to do just a couple of things down on the side here. So one of the just the hallmarks of EMS and the big pieces is we are kind of resuscitative experts and generalists. It's kind of the rest of the stuff. One of those big things when we're talking about resuscitation or in managing is we drill an awful lot from one of your first days in EMT school, probably was it the second, maybe the third class at the latest. You're already starting to talk about your ABCs and your airway management and breathing. And that's where all of our assessments start. If we get stuck and we go, oh my God, this scene is getting out of hand, we all go time out. Does this person have an airway? If not, we're going to get them one. Are they breathing? And if it is, are they adequate? And we're not, we're going to fix that. So we go into those steps all the time. Those are our foundational pieces that we work with. So those skills can be everything from oxygen delivery. How many of you guys have been doing this 10 plus years? Anybody? Okay, so most of you, hopefully, when we started, everybody got high flow oxygen, just flat out. Everybody. You know why? Because we could bill them. No, that's not true. Because the theory had been they are very likely, there's a good chance that they have some oxygen deprivation, so hypoxia going on somewhere, and some is good and it can't hurt and it might help. That was the theory, high flow oxygen. There wasn't a lot of science behind that one. It seemed to be a good idea, but about 10, 15 years ago, there was some stuff coming out already where it was, well, wait a second. There's a number of things, both at the cellular level. One of the things that happen is it's called, you actually hyperoxygenate, you get free radicals, it's called. So essentially, you're killing cells, you're making it toxic. You have so much oxygen in the system that it's actually hurting cells. So let's take those examples of a cardiac chest pain. So we have somebody we're thinking having a heart attack. The clot forms up in their coronary artery. Everything downstream is starting to get hungry because it's got blood flow interruptions. So, that's oxygen deprived tissue. Let's give them lots of oxygen. Except none of it's getting there because there's a big ass clot in the way, so it's not. But we're flooding the rest of the heart with massive amounts of oxygen. And then we're actually doing heart muscle tissue damage at a cellular level by flooding with that oxygen. There's another small piece that's kind of interesting, is it's in high doses, it can be a vasoconstrictor. So we can actually take those coronary arteries and shrink them up a little bit. So the rest that we want getting good blood flow isn't going to get it because we're shrinking it up a little bit. And so that's why that changed. So some of you have just taken EMR or EMT in the last 5 years. It's targeted oxygen. So for you guys here, what's your oxygen? So if somebody's complaining of difficulty breathing, we give them oxygen. We're still going to be judicious in our use, but we're going to give it to them. Other than that, what's your targeted SpO2 value where we start to think about adding oxygen? 90 is what you guys are using? Totally cool. AHA has been talking about 94, 90. Even some people are talking in chronic COPD where respiratory isn't the complaint, even going as low as 88 is probably okay. As long as they don't have other signs of shortening of dyspnea, great. Just deal with whatever their problem is. Their broken ankle is just fine if they aren't in distress and they're 89. We don't need to throw oxygen on necessarily. So if we're going to start adding oxygen into the picture, what is your best, or what is there a number that's a top end number that you try to shoot for? Just curious. If you do, if you don't, doesn't matter.
Just where we can get that SpO2 up.
Right.
To a sustainable level.
Right. So what I usually work with and what we've been working with at Dodge is if we can help it, we'll try and keep them around 99. Because if you get to 100, that's all our machine will read. They might be at 400. We don't know. That could be 100, it could be 104% of what's normal, but we might be flooding them and we won't know it. So if we see it at 100 and 99, 100, 99, 98, 99, 98, 99, 100, great. Just a thought, because now if you were to do blood gases and we pulled that out, we've been seeing 100, but if you actually looked at the partial pressures, we might be at that 200, 300, 400 mark and really flooding them. So if respiratory, if they're in respiratory distress and they really need it, great, give it to them. But even there, we can play just a little bit because 99 to 100 is all we need. We're not helping them any more beyond that. So something to think about. Go with what your guidelines are, but it's just a little trick that we've been trying to play with being targeted. So not grabbing non-rebreather right up front unless it would be, holy crap, yes, I'm going with that. But maybe we start at that cannula. So what's atmospheric oxygen concentration percentage? 21%, depending on which book you look at. So we already have plenty there. We put them on a low cannula, we're only going to add, we're going to put them to 23, 26%, someplace in that, and that might be all they need. And it's pretty amazing that, so you've worked in hospital as well, if I remember right. But that idea of, we used to bring on this chest pain and the nurses would rip that big old mask off and put the cannula on, and it, boy, as a young medic, those guys don't know shit. I'm what the blah, 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 blah. Well, go back to my younger self and go, boom, you don't know everything, okay? So it was something that it took a little bit of beating out of me, but when I started reading it, it was like, oh, that makes a heck of a lot of sense. So targeted oxygen is what we're gonna be looking for. So not everybody needs a vast amount of oxygen. One of the other tools, though, is we can upgrade. So we go from a cannula. You guys carry just cannula and non-rebreather?
Do we carry a partial?
Do you carry a partial? If you really want to have fun, most non-rebreathers aren't truly that, because where did those go? So this one is a non-rebreather. And how this one works is you've got these valves. So when they inhale, it's supposed to come back up, and all you're getting is oxygen from the reservoir and from the mask. So nearly 100%, not quite, because there's going to be leakage or whatever else. So you're talking probably 95 plus. If you really wanted to, and you wanted to be a little more targeted, you can pull those off, and you're allowing at least a little bit of atmospheric stuff to come in, and exhalation, is still going to happen. So you could titrate a little bit if you really wanted to be fancy. So you could make your own partial rebreather and pull all these valves off, and then you're probably talking that 80%. So if you want to be fancy, if you have a long transport and maybe you want to play, that's one option you might have. If you're already up to this, maybe take one off and then just do your best.
Can you give an example of when that would be a good opportunity?
So you're running 10, and they're not like just sucking it in like crazy, but you need to be running 10. You can't push that much through a cannula, right? And you're staying at 100. You're staying at 100. You really don't want to turn it down to lower than 10 because now with these on, then they're possibly going to be rebreathing CO2, which you don't want them to do. So by pulling these off, you're going to allow that atmospheric to come in. So now your FiO2, the amount of inspired oxygen that's coming in that flow, might only be at an 80% mix instead of 100% mix. So you're getting some atmospheric oxygen. So you're bringing that nitrogen and other stuff in, mixing with that to give you more of a simple mask. If you remember your class, that you're delivering just a little bit less. So if you were to pull those off, generally speaking, I'm going a little deep, but if you have that long transport or you have a long scene time and you're just you're in the middle of the snowstorm and you want to be a little bit more targeted, so you pull one off and maybe it does come down. So you're at 10 already. You really don't want to go less than 10. I mean, if the bag is collapsing, you need to be coming up anyway. So then we'll be fine. But you're at 10 and they're still, you can't get them below 100. Maybe pull those off, see what happens. All things considered, if you can't, 100 is fine, especially for the times we're dealing with, because we really aren't dealing with them all that much. There's a couple of other things to consider when we're doing oxygen delivery, which just crossed my mind. Why do most of us breathe? Most of us in the room, what? Because we have to. What in our body triggers a breath?
Well, it's carbon dioxide.
Well, sorry, it's over here. The brain, but I haven't taken a breath in a long time. My oxygen's going lower, 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 lower. I better breathe so I can get some oxygen. That way? Or my CO2 is getting too high, getting too high, getting too high, getting too high. I got to get rid of CO2. Now, we don't have an entitled CO2 to play with here tonight, but that's why most of us breathe, is because our CO2 gets too high. Acid base is going to start getting screwy, and the quickest way we can do that is by breathing and dumping the CO2. Because at the cellular level, we have that, oxygen and sugar, ATP is generated, but the byproduct is CO2. We got to get rid of that. Otherwise, acid builds up and the body gets pissy. So if you sit and you hold your breath, if I could do this, and I didn't even think about it until I was on my way down, which is why I was asking that. If I take, put a pulse ox on here, and you'll watch your CO2 go down and go down and go down, because I'm going to blow off a lot of CO2. Normal's 35 to 45, in case anybody cares. And we'll be down under 30. I'll take a big deep breath. If I do that right, even fat, out of shape paramedic John, I can hold my breath for a good 60 plus seconds. Sometimes I can get about a minute and a half. And it's hurting, it's hurting, it's hurting. My sats stay at 100 until that last few seconds. Then you start to see it drop off. And then I'm in the 98, 97, 95, maybe. And I take a big breath. But as we watch that end tidal, what we would end up seeing is numbers in the high 50s or 60s, because the CO2 is built up so much. Now I'm off-gassing all that CO2. So we use CO2 as our primary trigger for breathing. There is a subset of the population, though, that doesn't. And I kind of hinted at it before, but COPDers. Somebody who lives with chronic emphysema, chronic asthma, those types of things, where they're doing air trapping all the time and their body has learned, says, screw that CO2, I'm worried about oxygen, because they don't have any reserves. They breathe and they breathe in and breathe out, breathe in and breathe out, and that's it. Their oxygen sensor is what's triggering that breath in most cases. Well, what happens now, we throw them on pure 100% oxygen. What's the risk? Their internal pulse oximeter goes, oh, heck, I've got plenty of oxygen. I don't need to breathe. So if you remember, and your class was at least touching on that hypoxic drive is a thing to be aware of. I have never seen it in my career. I've not heard of it in any of my peers, although it is a risk. Usually that happens over hours and days in high oxygen environments, because the body is still doing its thing. It's going, yep. We probably should still breathe. Yep. Wait a second. And they might slow back down. Where you're most likely to run into this big issue, it's something you need to be aware of, because it could happen. In 30 years it hasn't, but it could. Where you run into it is you go into the nursing home. You go into somebody's home that's on home oxygen. And they've been told by their home oxygen people or their doctor or their respiratory therapist, or because they're the nursing home patient or the nursing home nurse that deals with chronic people on continuous home prescribed oxygen, don't turn that up above 3 or you're gonna die. Because that's a simple way of telling them that don't flood with oxygen because you might do this over hours or days. But we come in and they look about as blue as your shirt there, and they sound like a Smurf, and they're percolating like a coffee pot because they're so full of fluid and they're struggling to breathe. Yes, we're throwing them on 15. We're probably grabbing CPAP. We are going to flood them with oxygen, pressurized oxygen. And a family member might scream at you that, no, you can't do that. That'll kill them. That's where you can say, yes, in some circumstances. In this case, we're aware of the problem that might happen and we're ready for that. Because what happens? They stop breathing. Great, we breathe for them. It's not going to happen. They're so desperate for oxygen. Because I've had that nursing home. You hear the coffee pot down the hallway. We got them on 2x cannula. Good for you. yeah. Now that extra 4% ain't helping at all. So yeah, we very quickly escalated up there. Do you have nitro for pulmonary edema in your guidelines?
Our medical director does want that. That's something we haven't talked about.
So we can add that in and we'll just talk about it at least. When you're ready to add it, you can add it. So anyway, we'll spin back up. Pulmonary edema when we talk CPAP, if I forget, because yes, you don't know this yet, but I do have a shiny squirrel. Okay. Tough crowd. I got a smirk. We're good. You got almost a giggle out of that one. So why we breathe. So the idea of targeted oxygen helps us solve those other problems, or at least mitigate some of those other risks of flooding them. Because if they do have that hypoxic drive, we're not starting that clock on when they decide to not breathe. So oxygen in our world is a medicine. So we need to use it as a medicine. We don't always have to put it on. Just like backboards, they were the thing. When I started, we both started, everybody got backboarded. If you didn't see them fall, boom, they're backboarded. I don't remember the last time I backboarded anybody. I've scooped and used the scoop stretcher to get them on the cot, and I'm already pulling it off. So same thing. So much stuff has changed where they found out backboards in penetrating trauma are almost universally detrimental, and in most cases aren't helpful. So all these little things. Mask trousers, they were another big one. Anybody heard of masks or pneumatic anti-shock garments? Yeah. When I started, we had to do a whole separate survey. Every trauma got them. It was crazy. Even to the things we were talking about in the last session with IVs and permissive hypotension. We would put those on, squeeze them all the way up. 2 IVs were pouring fluid into them. And that's when you start seeing what used to be this nice dark red stuff turning into like pink lemonade, because we were just pushing the blood right out of them, diluting the hell out of it. And we wondered why, because we thought it was the right thing to do. So oxygen is targeted. Whatever your medical director wants you to do, but the 99 to 100 for me is my top end. And then AHA talks about 94, but in some cases 90. I like that you're talking about 90, especially if that isn't the main concern. If breathing's a problem, give them oxygen, but still appropriate. Okay, so a couple of things that you could add on in here, but let's see. Trachea, carina. I'm not going to draw all the lobes of the lung. But as it goes down, it keeps breaking up, going down into smaller and smaller bronchioles, and then eventually you get down to these little clusters, little balloonies. Has anybody done a cadaver lab, pig pluck lab? Did you do the cadaver lab?
We did up at Mayo.
Did you just do the last one?
It was last year.
Yeah, it was a hard
Okay,
one.
so you did that.
Yeah.
Tell me about what your impression of when you got to see actual lungs being ventilated. Describe what it looks like to you.
Huge. Like they went from nothing to something.
Yeah, it's
Okay.
Tara. You can see it. And then the cool part we took away, like, put your hands over
Yes.
Mhm.
to
Yeah.
emulate asthma. Fully bananas. Like, you are going.
Very difficult. Yeah.
Okay.
Yep.
So the material, we often, because we sit and play with Fred the Head all the time, we think of them far more as just big spaces and balloons. They're huge sponge-like material. It's very spongy kind of material. And then seeing all the individual lobes is kind of odd as well, because all we usually see is what we see there. Anyway, we're going to talk about the next little bit here is when we're talking down in that lowest parts of the airway, the alveoli. So a couple of things on alveoli are, where am I going with that? A couple of conditions, but basically they are small, teeny tiny little bubbles. They are the teeny tiny balloons. And so when we're thinking of the lungs, not big balloons, but thousands and probably millions of, and I didn't look at the numbers and don't quote me, but these little alveoli. Now, under normal circumstances, we take a big breath in, everything fills up and expands and they fill up. And so you have all these little branches and they all bubble off looking like little cauliflower balloons on the end of it all with all the little holes going on into it. And that's the surface area where all the capillaries are running across to pick up. So it's coming from the right ventricle through the pulmonary artery and then pushing across there. And that's where you get your gas exchange. So the CO2 that's in all the cell, or in the blood that we're trying to get rid of, diffuses back across into the high oxygen, low CO2 state. The oxygen floats back into there, and there's some more pressure physics that goes with that. But over those very thin single wall membrane capillaries and those alveoli, the oxygen goes that way and the CO2 goes that way, and then we let go, pressure built, we've built up this positive pressure and then we let it go and off it goes. Normally when we're breathing, we create, actually to breathe, we create negative pressure. Diaphragm contracts and goes whoop, and we create a bigger space. So now lower pressure because the volume increased, higher pressure out, goes on in, diaphragm relaxes, and now we create a small space to change the pressure, and we just keep doing that. That's ventilation. If you really want to get right down to respiration, that's actually the gas exchange at the cellular level. But in essence, that's what we're doing. So normally, it's we create a negative pressure ourselves, comes on in, we have the pressure differential, drops on in, those alveoli pop open, and as they close, usually they don't get all the way closed because there's reserve, and it's the fractional volume, oh shoot, forgot what it is. Basically, we leave about a third of the total volume available back in there, so everything stays nice and open. Great, that's normal. That's our nice young teenagers over here, and they're really good and healthy. Yeah, we're good? Okay, all right. Okay, just checking. I couldn't get away with that with him, so, all right. Because I'm guessing we've been around the block once or twice. Okay, so that's how things normally work. Now, certain things get in the way of that. So we were talking about asthma. So what happens in asthma? Why is that one of the issues? Is that down in here, or is that somewhere farther up in here? A little bit down further. So your bronchioles, the bronchi, those are going to become inflamed and swollen. And so now you've got the alveoli down at the far end of that, but you can't push stuff through. Or maybe you can get it in, but it just can't get out very, very well. So that's got to reduce space. So we create this nice negative pressure, but because this is such a passive thing, when we just relax the diaphragm, there's not a lot of active things happening. And if you've got this constricted space, so one of the tools, did you guys push against that asthma then, or you just... So one of the things in severe asthma you can do is active decompression. So if you've got somebody that's got a severe asthma attack, one of the tools some places will use is you actually take and push on their chest to help force that out. Or you have accessory muscle use that's going both in and out because you're trying to go in through a lot of small holes. Intercostals get involved and retractions and all that. So when we talk kids or even severe adults, you might see that accessory muscle use. That's trying to get it in and out because then they're trying to belly breathing. All those things are trying to help that what's normally a passive process become an active process. So that's a farther up one. So if somebody's got reactive airway disease, so chronic bronchitis or asthma, what's one of the tools in our toolbox? Bronchodilator. So a beta agonist, albuterol, is generally what we use. That actually helps bronchodilate. It helps that swollen, inflamed, irritated airways shrink up a little bit and open up. And that's what those are used for. One of the tricks or kind of tests I see in how well you're grasping respiratory when I teach EMT is have somebody with difficulty breathing. What's your first medicine of choice? Go ahead. Oxygen, absolutely. Oxygen is your first choice. But somebody that really likes to play with the extra ones jumps right straight to albuterol. Let's try a different thing. So is albuterol going to help asthma and reactive airway disease? Hell yes. One of the other problems ends up happening is you have heart failure. Remember we talked about heart failure, left and right part of the heart. So if you have a left-sided heart failure and it's not able to clear stuff out very well, but you got lots of flow coming back from the right side and it can't get gone or can't get pushed out the left side, where's it going to back up? In the right side, but in between in the lungs. And so now we have these weird pressures. So those little capillaries that are going all over here, they're getting kind of high pressure. Well, then they start to leak a little bit. And so they leak and the pressures aren't right. And so fluid starts to maybe pop through those capillaries. So now you start getting just a little bit of fluid buildup down in the alveoli. So now you take that by a million or however many of those little bubbly things and they're getting just a little bit of fluid in there. That's called pulmonary edema. So we're getting swelling, but because we're getting fluid into those air sacs down there. So now we have pulmonary edema, and how would that, for your assessment when you're listening to your lung sounds, what asthma would sound more like wheezing. Okay, what's that going to sound like when you're listening? Gurgly, crackles. So crackles is the hallmark, rails. And depending on how bad it is, it can be really rumbly if it's profound, like my little Smurf lady. And that was her problem. She was in horrible pulmonary edema secondary to heart failure. So what you're hearing there, that crackles. So for those of you who have hair, if you took your hair and rubbed it between your fingers, that's what it sounds like, or very much like Rice Krispies, or if you had a wool sweater and you were trying to rub the stethoscope across it, it would be that kind of scratchy, crackly sound. It could be as much as the more of a rumbly, but that crackles is the air trying to percolate through some of that fluid that's building up. They're flushing it out. The air's trying to get in and out. It's percolating through there. Is albuterol going to help that?
Not at the cellular level.
Well, not down at the alveolar level. It might now the problem is they also probably have some sort of reactive airway disease. So sometimes albuterol can help, but let's just talk pure pulmonary edema alone. There's nothing else wrong. So if we open these up, that isn't going to solve this problem because it's the heart that's actually backing up the fluid. So the albuterol isn't necessarily going to help that. Well, one of the things that albuterol also does is it increases your heart rate. So if we're already in heart failure, now we jack them up with albuterol, we run some more risk, we're making it work harder and it can't do it as it is, and we run a small risk there as well. Not saying not to, but it's not as simple as just, everybody that has problems breathing, we give them albuterol. Maybe not. So one of the things that we can do for this, the primary means, and this is where CPAP, continuous positive airway pressure, where CPAP was first introduced into EMS. And it's been a good 15 plus years. It might even be a little bit more than that. It's taken a while for it to filter on down, partly because the only way to deliver CPAP for the most part was using a ventilator or a similar device. Has anybody got a CPAP maybe at home, perhaps? Yeah? Great. So that same device would be needed to use. But then how do we program that on the fly, and getting it out to the BLS level was going to be tricky. A lot of ALS systems didn't even have it. We had to buy some very specialized equipment. It was expensive. So it didn't get out in widespread use. Minnesota is still ahead of the game. There are places that EMTs flat out cannot do CPAP. And I don't know why. It does have some risks. However, it can be a game changer. So what you end up doing with this, because it's all wet, so we've got that fluid built up in there. So the other piece is that now those alveoli become sticky. And so we exhale, and now they all close up together. And if enough of them close up together, we lose the whole lower lobes, or we lose a good chunk of it. That's why when we lay somebody back, we get a lot of that fluid covering a good chunk of those, as opposed to if we keep them upright. Folks that have got heart failure and they sleep in recliners because they need to be at a 45 or more, because it keeps all that stuff down low. It kind of percolates, it stays down in the bottom. We lay them down anyway. So the fluid itself can be a problem, but it also can make the alveoli stickier. And if we're not getting a lot of airflow anyway, and we don't keep the pressures right, they all start closing up. And so now we have a bunch of these guys that aren't there to take on because we need that surface area to get that oxygen done. If those are all closed up. So the tool that we have to help us with that, one of the tools, CPAP for continuous positive airway pressure. So what we end up doing is we have to have a good seal. So you have to have a mask and to be able to get that. It creates a little bit of back pressure. It does not let everything get back to neutral. So when we talked about that breathing cycle, we contract the diaphragm, goes down, pull in all this air, and then it goes on out. Well, before we breathe again, pressure inside the chest and outside is going to be the same. What we're doing with this is we're keeping just a little bit of back pressure. So this goes almost to neutral, but not quite. So it stays slightly positive. So so the idea being there's just a little bit of pressure back all the way down here. Instead of them being clamped up, they stay popped open. It keeps just a little bit of back pressure. And most CPAPs are oxygen driven. Your one at home, my wife's at home, is air driven, which is fine because they just want the pressure. Most of ours, because we have oxygen as a source, work pretty well so now we're putting in a pure oxygen environment on top of that. So now we're putting more than 21%. We're probably putting in 50 or 80%. And I do have the notes here somewhere. Here we go. I can look at the actual percentage. The FiO2 is much higher. So not only are they struggling to breathe, now we're creating pressure to keep those open and giving it a very high oxygen environment for that to happen. And so by putting that pressure in, that keeps those popped open. The other thing it can do is because we're adding that pressure, it actually can kind of push that stuff back out into the vasculature. Now we're matching some of those pressures and we can push that fluid back out. So those are some of the pieces that go into play on there. All right, so how you use this is you have to have a good seal. Sorry. There we go. Probably need to sharpen that. Here's what comes in your kit. So you said you have large and medium? Yep. So do you have just extra large masks, or are they both kits, some big, some small? Kits. Okay, so you may try and grab the right one. Otherwise, what you may end up doing is you try the medium and it's not working, or you try the large. You don't have to change this all out. You can just change out masks. But here's your components that come with that. This is the actual CPAP itself. This is the unit that generates that. When we're talking about the pressures here, it's in centimeters of water. I don't know why they use that, but that's the measurement. Whereas, blood pressures are millimeters of mercury. Somebody smarter than me can help you with that. But this is the device itself, okay? And let me see here. So this hooks up to your flow meter. You can start if you're not running a neb, this will run and it will go to, if you do 5 liters, you're going to get 5 centimeters of water, 5 centimeters of pressure. That's the usual starting point for CPAP. So this is going to hook into the mask. I think that's the better way to do it. Yep. So right there, I was so cool with my cord. All right. So that's going to hook on the front. This is going to go on 5, and as this runs through, it uses a Venturi effect, but it can generate, and then the manometer over here will tell you where you're at. So you put this on a flow meter just like normal oxygen, you flip it to 5 liters per minute, you should see that get up to 5. Now, it might be just a little low, so you go up to 6 or 7. You can then use that to fine tune where you want it, okay? If you want to go to 7, you can, I believe you go 7.5, so you're basically doing 2.5 increments. You can go up a little bit more. Generally speaking, 10 is most places top end. You don't have specifically in your guidelines. If you're not seeing relief at 10 centimeters of water, I would stop at 10. You're not going to get much benefit and you run even more risks when you start getting even higher than that. But how we do this procedure though is like everything, you need to have oxygen flowing before you do this. However, it does use a fair bit of oxygen. So if you've got it on a portable tank and you're only at about 800, be prepared to start switching out tanks soon or getting moving to your truck. This is just John's personal practice. Unless I can't get them moved right away, I don't start this until I get to the truck. Just simply because if I'm going to sit here and fumble fart around and I get distracted, get them on that dang cot, let's start moving. We'll start this in the truck. Okay, there are exceptions always, but for me, it's less likely I'm going to be able to run off my M tank or H tank or whatever size tank you've got, but you at least run off your truck's oxygen. Patient, they've got to be able to get a good seal. Although I would bet even with this, we can probably get her right on up on you. A couple of tricks I've heard is if you have somebody with a really heavy beard, is putting or you don't want to do petroleum with oxygen, but you can use your Surgilube or whatever. So you can do KY.
Yeah.
So you can sometimes get that. I mean, if it's an extreme situation, I suppose you could probably shave a little bit, but that would be a pretty extreme. I've seen people talk, I have not seen it done, but have talked to some folks that have had some success with that in really severe cases. But I would bet Joey over here, we could probably, because of the way these all mash up, we could probably get a good enough seal to get that. But because it needs to be continuous, we can't have any leaks because otherwise that pressure drops off. So if your home one leaks out, eventually it'll either alarm at you or it'll yell. Same kind of thing. This won't yell at you, but you're going to see your pressure's not off. So you can do a couple of different ways before you actually put it on them. You maybe have these out or super loose. A couple of things. We'll go into indications here in just a second. I just wanted to show you this stuff. So come on. Oh, it's my first day. Sorry. All right. So we got that up, ready to go. Before we put it on their face, we want oxygen flowing because they're already struggling to breathe. They're going to feel like they're drowning or can't catch their breath or whatever that happens to be. This is going to feel funny. So some of them have had it before. Have you ever, some of those questions, have you ever been intubated? Have you ever had to have CPAP for this before? Those would be good questions. If they've never had it, describe what it is. This is going to feel really funny. It's going to feel like we're covering your face up. When we are, but there's oxygen going and this will help you. And so you may have to coach them a little bit. We can put it on there, and once we get the seal, fold everything back, get it all winched up, and now we're on. So, a couple of things that they have to be breathing. This will not breathe for them. If they are apneic, it's just going to keep positive pressure and isn't going to solve anything. It is not a ventilator. They have to be breathing. Okay. Couple of other pieces. They have to have a systolic blood pressure greater than 100 because what are we doing? We're pressurizing their chest. We're adding a good 5 to 10 of pressure. If they have low blood pressure, one of the concerns is they're very dependent on the vena cava to come back and bring the blood back to the heart. If we pressurize that and they have a low blood volume or if they have a low blood pressure, we can actually crunch that or squeeze that so the vena cava is now restricted. That's why we end up putting pregnant women on their left side to get the baby and belly off of the vena cava. So we try and put them over there because if they're laying like this, it's compressing it and return blood flow becomes a problem. Okay? So we want to make sure that they have a pressure of greater than 100. They have to be breathing. And under your guidelines, did I give that back to you?
You did.
Okay. Just make sure we cover all the different pieces. Your guideline says they have to be breathing greater than 25 breaths a minute. Now, in most cases, I get that. They probably are going to be trying to breathe that fast because they're in respiratory stress. They're going to be struggling, and that this would be that case. I'm trying to think of the other indications. So, what's that?
Odd number, 25.
Well, okay, so 26. Okay, so it's greater than 24. So 25 or more. Okay, see. So they have to be awake and follow commands, is over 12 years old and can fit the mask. Ability to maintain their own open airway. So if they've got big old dental problems, they're puking, they've got blood coming out of their airway, not going to work. Systolic, so greater than 25, 100, greater than 100 systolic. They likely should be using accessory muscles because they're actively trying to solve this problem. If they aren't working that hard, then maybe they're not there, or they've gone so far that they're about ready to be in impending arrest. And then signs and symptoms consistent with either asthma, COPD, pulmonary edema, CHF, or in some cases even pneumonia. This can be a helpful tool. Okay. So where was I going with that? Okay. So got to be 12 or greater, be able to follow commands, all those things. Really struggling to breathe. They have to be using accessory muscles, BP of at least systolic of 100 or better. All right, contra, patients in respiratory or cardiac arrest. Patients are suspected of having a pneumothorax. So you have a high index of suspicion of that, unequal breath sound. So you have nothing on one side, something on the other. Now, if you have something where it's a pneumonia and there's just nothing down there, again, if you're worried about it, because this will become a tension pneumo very quickly. So now we have air outside the lung, inside the chest, especially if it's a hole in the lung that's causing that, we're going to make that significantly worse. Okay. They're at risk for vomiting if they have a tracheostomy. So this isn't going to work terribly well because now we're just going to blow gunk out of that. Might be entertaining, but probably not. And here is lack of proper PPE. So this is one that you do because it's a really aerosolizing, nasty kind of a thing, or the potential exists for it. You do want to probably get completely level A suited up, but use all of the stuff available. If they're impaired mental status or not able to cooperate, you really want to be cautious with this one. If they've had failed attempts at CPAP and not done well with it in the past, that's another one to be worried about. Upper GI bleeding or history of gastric surgery, again, we're worried about esophageal varices or bleeding or throwing up into the airway. Complains of nausea or vomiting. They just don't have enough respiratory effort to make this work. So it's not an absolute contraindication, but it's one you really want to be looking at. If they're only, maybe they need this and help, but you can't just put it on and walk away. You really got to watch them. If they have excessive secretions, because we can't get in there and do that, or they have a facial deformity that just won't let that happen, like a big puffy beard. No. Okay. So those are your big ones, and they'll be in your guidelines as well. So those are the big high points to it all. So when you do that, any firefighters in the room? I remember there were a couple. You guys fire? When you put your SCBA on, you are actually, I think it's a 3. You get about, you have a slightly positive pressure built up in your mask. So you're getting that just a little bit of resistance. And that's to keep, if you do have a leak, it's to keep stuff pushing out, keeping the bad stuff from going in, so it's going to blow out. So you've already had that if you've been on SCBA before, because it does have a slightly higher pressure, and I believe that's at about a 3. And again, it's been a long time since I did the backwards funny looking hat. But anyway, so that's the whole gist, is you basically put this on, and I won't put this one in case somebody wants to try it. Do we have a tank close by? Sorry. You want to just use this one? Perfect. That's all right. So I just basically want you guys to kind of hear or see what it's doing. I suppose I could just put it on so you can see it, but
In theory, there should be oxygen in it.
we will find out if I can turn it on. There we go. Hey, you are at about $1,000. Okay. Is there somebody that desperately wants to see what it feels like?
I will,
Great, come on up.
after I go to the bathroom.
Sorry, just
Clarify something
Yeah,
for me.
right ahead.
So you said water. Is there already water in there?
No, it doesn't actually
Oh,
have water,
okay.
but that's what the scale is.
Oh,
So when you take a blood pressure, you just call it 110/70. That's actually the pressure to get past the BP cuff so it totally occludes at 110 millimeters of mercury is in a vacuum tube. That's just the scale. We don't actually have water. And
There's not actually mercury in it.
and there's not mercury in a BP cuff. Same concept though. So, but it's just done that way. Now, if you had chest tubes and hydroseals, then there's some water and there's the bubblers, but that's a whole nother day. I still think we should be able to do that on the street, but what do I know? Helicopters get to do it. Go ahead.
And Andrew's gonna
Yep.
figure this out really quick. What does it feel like for a person who?
So the first thing that most people, especially when they're struggling to breathe, is it feels like they're being suffocated because you're putting this mask very tightly on their face and strapping them in. But what they'll feel is a bit of pressure. So what they'll find is their inhalation will be slightly easier because it will push air in because that's got that 5 or 7 or 10 of pressure. What they'll feel going out would be a little bit of resistance. So that might feel a little funny at first, but what they will feel is their work of breathing generally, because now we have all those alveoli starting to pop open and much better oxygen, their distress level should go down within a couple of minutes. You got to coach and talk them through it. If they flat out won't tolerate it, then you just switch back over to a high flow mask, and that's what you do. But if you coach them, then most of the time they need to do something, and your confidence in this as a tool will help. Okay.
Should we be coaching them to be taking slow, deep breaths?
Just breathe as normally as you can.
Normal? Okay.
So
Yes, sing while you're at it.
let it go, let it go.
You know, nervous?
Not a waterboarder.
If you use diesel, it's not. Okay. So I'm going to let you do your own mask administration. Give me 2 quick seconds here. I'm just going to pre-thread these a little bit. You want your eyes bugging out and freaking out? Okay. So I'm going to give this to you. So just going to show you. But you just hook up to your regular flow meter, and are you ready? Okay. I don't have a 5, so I'm just going to 6. And go ahead and put it up against your face. Get a good seal. Okay. So then we make these adjustments. Luke, I am your father. So, oh, geez, I've already got her at 10.
It's a lot.
All right, so I switched to 4. Just exhale. So just
Does it feel like pressure?
take a deep breath in and then just let it out. And then just then stop at the end for just a second. There. So while she's at rest is going to give you your marking. I've got her setting at 4 liters per minute. Go ahead and breathe as much as you want. And so when she breathes in, it goes to 0 because she's pulling all this stuff in. But when she's going out, she's pushing out against that. So it actually goes up a little bit more than that. But as she's going out, it should be about 5, 6. And then as she's getting ready to take the next breath, it'll still be there. And then it comes in and goes to 0. So if anybody wants to look, go right ahead real quick before we get done with that. Yeah.
How it could be freaky. Yeah. Interesting.
Okay, you want to take it off? Go right ahead. Okay. So, part of your post-assessment, once we get this and she's comfortable with it on, going to re-listen to lung sounds. Are we seeing any improvement? Maybe the crackles are decreasing? We should see an increase in, hopefully, in pulse oximetry.
Yeah.
Those things that good.
Say that again? Pulse oximetry? Absolutely. Now, with a caveat that you need to know that what your information is correct, okay? So if you've got cold fingers and it's kind of coming and going, if your waveform or if you've got just the finger one where maybe it's just got the bars, if that's kind of fluttery and not real sensitive, I'm not so sure about those. But if you go to feel a pulse while you've got the pulse oximeter on and you watch that waveform and you're feeling a pulse and a waveform, or you see the bar going nice and steady and they're matching, it's pretty dang accurate.
And the O2 part of it is very like.
Yes, yes, very much so. Oh, all right. Okay. So, what do you think? Doing good? She should be maxing out at
Yeah, she's
100.
gonna be at 5 million.
Well, we're going to be at 100 and then some probably.
Is this exactly what a CPAP for someone at home looks like?
Doesn't
wow.
necessarily look like this because this. So
Might not be that.
the process is the same thing. The pressures, you're doing exactly the same thing. And what we're doing at CPAP at night is we're not so much about the alveoli, we're more about these soft tissues high up here that are all floppy. So anybody heard of partially obstructed airway? My wife hears them often. She clears it by elbowing me. I roll over my stuff. Again, I don't recommend that for clearing airways, but okay. So you good? You get not? Oh, I'm sorry. Yeah, we're clearly at 100. 100%.
Yep.
What'd you do?
We cannot hear you. It's on. Your
80
pulse is one's at 94. It's at 88.
It's 88. All right. Are you comfortable enough to take it off now? Okay. Let's do that for just a second. Take it off when you're ready. Okay. Very good. So, oh, here, sorry. You're welcome. Okay. All right.
Yeah, it was a lot. When it
So
was
now
that time.
imagine you got pulmonary edema. You feel like you're drowning and struggling already and you can't catch your breath.
Yeah.
And so your body positions in all tripod. You're trying to get your airway all lined up and now you throw this thing on your face. That's going to be a pretty scary thing to deal with. So making sure you're confident and talking them through that and being empathic in that idea of, I know this is counterintuitive, but this is really strong oxygen and it's a little bit of pressure to help get that into you. It's going to help you.
So where did that,
So-
where,
So your manometer is on this side here.
oh, that's why I couldn't see it.
So, and when I had it at 4, it was sitting right about 5 or 6.
Okay.
When I had it at 6, it was actually already giving us 10. We had such a good seal and everything was working right. Okay. All right, that's the gist. So the types of patients you're going to want to do this on are pretty much most of your respiratory distress or respiratory failure patients, let's say that. What's the difference between dyspnea, shortness of breath, and respiratory distress? Anybody know the difference? Respiratory distress. Tell me something. What would be some of those things, or what would be the defining moment? But they're holding their SATs. They're working much harder to breathe, but they're holding their SATs or close to it. So they're still there, they're still holding on to it, but they're doing everything they can. So they're in distress. Respiratory failure is you're doing everything you can and failing to hold your SATs. So what we often call respiratory distress sometimes is respiratory failure because they can't compensate. It's that compensation is kind of that dividing line. Now granted, there's grays on those transitions. But if you have somebody that's doing everything they can and we're doing everything we can with supplemental oxygen and they're still not, now have impending respiratory arrest. And then we need to start thinking about other alternatives. A couple of other things you can do. So this is classic pulmonary edema secondary to heart failure. This is a classic tool for that, but it can work with asthma because we're pushing it in, keeping everything popped open. Emphysema as a part of a COPD. Emphysema is you've got all those little clusters. A lot of them have popped. And so instead of having 10 or 15 little cauliflowery looking alveoli down there, some of them have popped and formed into only 4 or 5. So you don't have as much surface area left. And some of that gets trapped and you get those problems. So this can help with some of those things as well. Asthma, some pneumonias can be helpful, especially if it's loose and we can push those, again, collapsed on up. It does help a bit with those bronchioles and the big upper airway issues as well, but they got to be struggling to breathe. All right, so the CPAP helps with all of those different things. Don't use it, again, low blood pressures, they're under 12, can't get the mask to fit, they're pukey, secretions, all of those things. Now, we have some people that are having asthma, reactive airway disease, COPD problems. This is a HEPA filter, so anything exhaled or back in and out should be better here because it's helping. But what we can do is, if we really need to, is, I think we can, so there it goes. We want to do a beta agonist. So we get this prepped and ready to go. We leave everything ready until we get to this point. Then you can take, with just a single oxygen source, you can pop this off. Where's the rest of my neb mask? So I put my, do you guys do the 2.5 milligrams or do you do a double?
2.5.
You just do one? Okay. Our guidelines, we double it. Not sure why, but if one is good, tube's better, I guess. Okay, so we put this on, we got our fluid in. A friend told me, don't flow oxygen until you get the cap back on. Don't try and do it while it's flowing. I've done that. Yeah, really? Yeah, I think everybody has at one point. I get a little ahead of myself. All right, so, okay, so this one's going to the tank. What we can do with this one is we can take this off. That becomes an oxygen source. You do the handheld, you just need the T adapter. That's where it goes. Sorry, guys.
So maybe you can buy the adapter, not
Yep,
the.
nope.
wonder if we should make
So if you have a handheld nebulizer kit,
one, Joey.
so if you have the handheld, it'll just drop into here. Problem being, once you open this up and you start letting air go on out, we're stealing some pressure. So now you have to about double it. I'll look at my, So you can add a neb under pressure. So if you have somebody that you have asthma that you want to do CPAP, but you also know your beta agonist albuterol is also going to open airways up, we can do that nebulized under pressure. And all right, I saw it someplace else, but once you add in the neb, you have to do about half again as much or double the amount of flow because you're stealing some of the pressure to generate, to get the neb to go. So you basically have to bump it up a bit.
Remember to increase the oxygen flow by 7 liters per minute.
Oh,
in order to
nope,
drive
just
the
flat
nebuli
out. That's what it was.
while preserving
Just
the
add 7 liters per minute because it's going to steal about 7.
Add 7.
So just add 7 across the board. So if you're at 5, you go up to 12. If you're at 10, you're going to go to 17 or 15, whatever. Of course, because that's about where you flow your normal nebulizer anyway. So it steals about.
Number of eggs and cups of flour and shit.
She likes
I
you.
was asking about that.
Okay, so actually much simpler than it looks. Now, if you really, really are struggling, this is an additional oxygen port if you really want to get close to 100 of FiO2, because this is mixing atmosphere and, so I think it's running at about 80%. If you put another tube from another source, you can really pump that up. You shouldn't need to. We're sending plenty in there. That's what that other tube is there for though. Nope, just T adapter goes in the middle. So green would be your backup or your neb flowing. You put it in the middle.
The mask
Yep.
and the CPAP.
Yep. So it just drops in right there. If I remember right, or just look up the guys here, the BLS Systems. They've got it's a short 3-minute video. You guys can just double check or re-watch one more time. But that's the gist. And so now you run your neb. Again, reassessing your patient periodically, but between the two, especially so for a reactive airway, asthma, COPD, that can give you some pretty decent improvement in your ventilatory status. It should make them better. No, you cannot ask him. Yes.
If I feel like I can't get that figured out, can I do a regular neb first and then apply CPAP?
You could. So you just have to make a decision on what is going to be your better value. Yeah. So if they're struggling that badly, my guess is you probably would have started with a neb if it wasn't over the top. If this is, you're over the top. So in a traditional, my practice, just guessing what you're doing, I'm probably beating the heck out of this microphone. You probably are going to do a neb first because that's what you're used to doing. That's your next year game plan. So, but if that's not working, then we go to CPAP. So.
Could always do that with neb running while you're getting that ready.
Exactly. So
And then if need be, you can always run a second neb through the CPAP.
once you have time to sit and think about it and remember. So the other thing you could do is just we could add in, they probably can even send you instructions on how to add the, yep, yep. So, and they show it like this so that
You can see the flow meter.
you can see the flow meter better instead of it just being on the one side. But anyway, okay. Very handy tool. We use it, I don't know, half a dozen times probably a year, maybe a dozen. It makes a big difference. Where this really made a difference was back in the day, so working at Lakes, this is probably 15 plus years ago, maybe even 20 now, was where we were looking at doing RSIs, and this was one of those cases, is those really severe respiratory problems, especially pulmonary edemas, being able to get control of their airway so we could bag valve them and get them under control and do our breathing. The incidences of these, once we added CPAP, we were turning people around. By the time we get to the hospital, they were much better. It really, really reduced, and in fact, it delayed our getting RSI, which is the paralyzing and then intubating. It delayed us getting RSI by 5 years because we were turning around the bulk of the patients that we were complaining about. That's what we need to do it for. That helped.
Would we ever
So.
stop using it en route?
If you think you're developing a pneumo, certainly. If they will not tolerate it, if they become altered to the point where they can't control or help you with it, if they stop breathing, if they do any of those kinds of things, we'd have to get it off there. They start puking, all that, because you can't do that or you're debilizing that right into their lungs.
Would they ever be well enough?
That's the rub. So now you're better, great, we take it off. But did you go right back into the same problem? So in most cases, my recommendation and my practice has been, if it's on, stays on, and it's working, even if they're sitting here going, heck, I feel much better. Well, good. If it ain't broke, don't fix it. Leave it the heck alone, all right? Once we get to the hospital, I'm switching over as quickly as I can to go over to my tank. We get on inside. I've already called radio report. We have CPAP running. It's oxygen driven. We're going to need to switch over to your wall stuff as quick as we can, maybe get them that heads up. Let them or their RT folks decide if we want to take it off and do a trial. Because then, now you've got a whole bunch of hands. If he goes to crap, now we have help. Because it's probably just you, or maybe you and me in the back. That's not a lot of hands, and if they go to crap on us, then what's the point? If it makes it better, we'll leave it alone. That's my opinion.
And always be listening to lung sounds.
Yep.
Very periodically.
Yep.
If you lose a lung,
So like, yep, so it should be improving, but if now suddenly, why are they having a hard time breathing again? And we listen in and go, oh crap.
Watch for tracheal deviation and distended neck veins.
So we are creating those risks. So much like everything we do, there are risks that go with this. This is not trivial stuff. This is real medicine, and you're practicing it in a very unusual environment without a lot of help. So lots of stuff to think about, but it can be a game changer.
And you hit at 2 in the morning.
Very much so. So nothing wrong with checklists. When you guys want, I have a really good one that talks about career resource management and maybe how do you implement a checklist process into a couple of those key high risk, low frequency procedures. We don't do any of those, so never mind. But some of that kind of stuff. But for these especially new ones, just a real quick, it only needs about 5 or 6 steps, but just enough, like the T adapter with a picture of how it goes in, so you're ready to go. And just that 2 o'clock in the morning going, holy crap. Okay, that's what I need to do. Nothing wrong with that. I refer back to my guidelines and my checklists all the time. We have our memory ones. So if you think about aviation, there's certain things you have to be able to do, just purely from memory. But that only goes so far. So aviation, this is part of my lecture, but they have what's called aviate, navigate, communicate. If they have an emergency, aviate, fly the damn airplane. Because too many big crashes happen because everybody's farting around with what the problem was and forgot to fly the airplane. Okay? And then navigate, fly it in a safe direction. Okay? Then you start communicating outside. What is our automatic just memory item? ABC. Fundamentals, get your airway under control with your basic tools. You can manage an airway pretty damn well with just simply an oxygen mask or an oral airway suction and a BVM pretty well, at least until you can add in the rest of your tools. So get the best of those basic tools that are just simply muscle memory, then pull out your checklist to get the rest. Same concept. So this is CPAP, continuous positive airway pressure. Has to be breathing. All those other indicators. There's something out there that's called BiPAP, which is biphasic airway pressure. So when you're going in, you might be at 15 because it's helping push it in, and then you might be going out at 7. So it's 15 over 7 or whatever the numbers are. There's all sorts of calculations you can do for that. It's a neat tool, and it's even more effective than CPAP, but you need a ventilator or similar to do it. So that's why that isn't out there. So there's some places, and you guys don't do any interfacility transports. You don't do hospital to hospital. Okay. So that's one of those struggling ones where, so you take a hospital like Wabasha where they want to do a transfer when they have a BLS truck. They're on BiPAP in the ER because they're having these same problems, but now they can't send them on BiPAP because the BLS can't take us BiPAP. So can they be okay on CPAP for a little bit? Those are some questions that come into play. So it really doesn't impact, but if you hear the term BiPAP, that's what that does. So similar concept, but it's now in is a little bit higher than the out. That's the only difference there. CPAP, BiPAP. And then we'll add in the last piece. They stop breathing, or we're to such a point that they're breathing so slowly. They're only breathing 6 a minute. They're altered. They're not doing well. Now, you all saw in your books, right, when you took it. Anything less than 10 or greater than 26, you bag them, right? Well, many of you have seen enough people breathing fast that they're not going to let you put a bag valve mask in front of their, doing a C&E technique and try and breathe for them. This is bad enough. Now try doing that. Good luck. On the other end of the spectrum, though, they might be gorked out and kind of going, and maybe only breathing 6 a minute. So we can add in bag valve mask ventilation. So I'm just going to show you it here, and I'm going to let everybody practice and play with it in a little bit because it's a good technique. But, so we got our C and our E technique, right? And we're going to, oh, hey, I should probably move. He does. Well, I like that.
It
That's,
might be because there's a big plate attached to his lung.
ooh. All right. So just good old, so if they're, I can't even say the word, bradypneic. So if they're breathing too slowly, so we'll do our best, but maybe they're taking a breath. So we'll give them an assist on the one breath, and then in between we'll give them one more, just enough to chest rise, right? And then with the breath, and then maybe in between, whatever that is. Maybe, because we're running oxygen, if they're still breathing, great, so they're gonna get their own breath. Maybe we help it a little, and then if in between, we'll give them just an extra breath every now and then. Maybe that does what we need it to do. But if we started out in this state, or we have a reason to believe they've got an asthma, or they've got that heart failure, and they've got whatever it is, now we can't use this device, but is there going to be a value in keeping those alveoli popped open and oxygen pushed down there? We can now add in this device, PEEP, which was spelled correctly, you said? Did we graded? Okay. Positive end expiratory pressure. It's doing the same damn thing this is, except we're going to be doing the breathing for them. So if you look on here, there's your measures, your gradations. So I think it comes at right at 5. So usually we start at 5, and if we need to or we're needing help, we can go up to that 7.5 or so, max out at about 10 if you really need to. With this one, if we're getting to a point where we need to bag somebody, we may as well. Now, we just figured out your yellow ones don't have the adapter for this, but these come off of here, okay? Some of them will have a port off on the side that you can tie into, which would be, I just lost my adapter. There it is. So this comes like this. So it may have that adapter on the side. We can tie into that, and then great, we've got that. But in this case, we're going to put it on the end, and then we'll see. Let me jack this up a little bit. I'm going to exaggerate this a little bit. Let's see. So, all right. Versus I don't know, is that really a big difference?
No,
We probably have some leaky lungs. But the theory would be is when I put this on, they should stay. Yeah, it's a difference. Because we're keeping that back pressure. But you have to have a good mask seal. So this has to be done that way. Or
In essence, you're putting your thumb over the end of the garden hose.
essentially. This might be a little too small, but we'll try it. Same reasons you do it for a breathing patient. Okay. Yeah, I think let's just try this. Yeah, I think the 3 is a slight bit too small. Sure. No, we just have the baby one. That's all right. Good enough. Let me just. So so in essence, as long as we have that in place, we still have a good secure airway. We have that seal, then we can keep that pressure. If we have bad mask technique, so if we're kind of, well, great, I'm getting some of it in there, but if I'm leaking, we're not going to be able, it's just going to go back to neutral. So if we want to keep that negative, or excuse me, that slight positive pressure, okay. So, as long as I'm on the subject, I know I'm exaggerating all this for you. So how much air do we put in? Just enough to get chest rise, right? That's the theory. So one of the things that an adult, this has a lot. So I can really overventilate somebody. I know a number of services, including us at Dodge, we've switched over to a child BVM in our adult child kits because we don't need more than that. we'll get plenty when we do it that way. So it's just one thing to consider. But just enough to get chest rise, okay? And it's an inventory control issue, so now we'll have to have 2 instead of 3 different sizes. So anyway, so this would be used for the same indications of that except for not breathing, and we have an issue with, and we want to be able to keep alveoli popped open, other forcing back through the narrowed airways, maybe for some of the lower respiratory problems with asthma, those other kinds of things. So if you're having to bag somebody that is breathing or is in respiratory arrest, consider PEEP at 5. It's not going to hurt much and probably will help. Okay, you can pass that around. We'll come up and play here in a minute. One thing of consideration, the one article I just read today to refresh on all this stuff talks about even in cardiac arrest that may be warranted. That's counter to what, do you guys use rescue pod at all? No. So rescue pod does the exact opposite. If anybody heard of rescue pod? Nothing. Okay, whatever. Okay, so the idea of cardiac arrest and CPR and the staying on the chest as much as we can is creating negative pressures in the chest, which is why we limit how much, just enough to get chest rise so we don't take away too much of that. And we only interrupt it briefly because it takes a good 5 to 10 compressions to get that negative pressures where we want. There's a device called Rescue Pod that fits in just like that, except it does the other end of it. It doesn't let it get quite back to neutral in a negative side. So it stays slightly negative in the airway, letting the heart refill better. So that would be counterintuitive to PEEP. It does the other end of it. That's not a respiratory device, it's a circulatory device. And if you're not using it, it doesn't matter. So a note to at least mentally when you talk with the doc, do you want to do that during cardiac arrest or only once you get ROSC? It's just a good question, because you are keeping a slight positive pressure, which is going to counter what you're doing with the compressions, creating negative pressure. So there may be some issues with that. That'd be about the only one I'd worry about a little bit with PEEP. And PEEP itself is not specifically addressed in your guidelines currently, is that correct? You couldn't find it? Or you don't know where it's at least? Okay.
It's in there.
PEEP is a very nice tool. Again, you have that asthma that went, do you have inline nebs where you can bag it into?
Yes.
Okay, same concept. So if we're gonna do that, maybe throw on just a little bit of PEEP while we're putting it there. So if our belief is they're down and not breathing because of reactive airway disease, heart failure, whatever, especially those that are not breathing but still have a pulse, these are great tools to have. But PEEP is just CPAP for a BVM. So, opioid overdose with respiratory depression or respiratory arrest, what is your first line?
Narcan.
Way to be wrong boldly.
Great.
Yes,
Somebody had to say something.
the damn cop got it right. I like it.
What did he say?
Bag valve mask. Breathe for them. You can run an entire heroin overdose with never using Narcan. Okay? So, breathe for them. That's all we need to do. So, in a few cases where I've done consulting with, I've had a former sheriff talking about, should we even bother carrying the Narcan? I said, that's up to you guys. I mean, you're getting it for free, but there's no guarantee. Now, do you have to, inventory, are you going to be able to replace it? You have to make sure your bag stays within the temperature. So I can give you a bag valve mask that's got very few of those problems, and you can solve everything from an opioid overdose through a stroke and cardiac arrest and diabetic reaction and everything that might have a respiratory component to it. Good point. So, the big problem we run into is it's the miracle drug because everybody talks about it. It reverses it, and man, it's like, oh, praise him, we got him back and everything's good. Problem being is if it's not a heroin overdose, if it's not an opioid or similar, it's not going to work. So there again, if they're so drunk, boom. If they've got so much Xanax that it knocked them out and they're not breathing, why isn't it working? Why isn't it working? They stroked out. Why isn't it working? Let's give them some more. Let's give them some more. Well, now we're 10, 15 minutes into it. They're not having a pulse either, and great, isn't that lovely? So that idea of your fundamentals are still there. Opioid, what are some of the signs and symptoms that would make you think that? So as the patient's presenting to you. Certainly could, but you know how many people I've seen? You know how many people I've seen with needles hanging out of their arms? Most of it I've seen has been smoked or just snorted or oral.
Respiratory depression,
Pinpoint pupils is a classic, and respiratory depression or arrest is a real strong one. So if you're doing your assessment, you have somebody that's in respiratory arrest, great, let's get that bag valve on them, let's start breathing for them. And you can do that without oxygen even. So if you've got it handy, go boom, start breathing, add the oxygen after the fact. You still have 21% oxygen. They're not in high demand for oxygen, they're just not breathing. Let's give them what we've got, and you can do that. I ran probably the first 5-6 minutes of it without ever hooking up to the tank, and we were already starting to get numbers coming back. It was awesome. So don't discount just fundamental bag valve mask with a good head tilt, chin lift, jaw thrust all the same time, C and E. Didn't even have the oral airway, and we were just getting it. You could do that and manage an airway really well for quite a while. Now there's all sorts of things that come into play. As soon as you can get them in, go ahead and do it. But then, hey, I noticed they got pinpoint pupils. Damn, they're not breathing. Their pulse is okay, but you could stop right there and just breathe for them, transport them into the hospital. Everything's good. Absolutely. So you could do that. You could take this and toss it right out the window and be just as successful. Okay? Just saying. Now, if you want to add Narcan in, nothing wrong with that whatsoever, but make sure we're doing the fundamentals first. Yep, I see pinpoint pupils, we're bagging. Hey, we're going to be transporting this one because here's some other risks. Now we get them back, and now they don't want to go. And they're alert oriented and know what's going on. Can we force them to go to the hospital? Even in that particular case, holding them could be a little tricky. Probably could get away with it, but so great. Let's get them on the cot. Let's get them in the truck. Let's start bagging them. We're doing okay. Go ahead. Let's give them some Narcan. Let's see what happens. Great. They come up. Everybody's happy. They're all remorseful. Everybody goes home. Everybody's happy. Kumbaya, and that's all it is.
They're not usually happy.
Now I'm gonna push back a little bit on that. I've not had anybody come up fighting. I've had people come up confused and a little feisty because they're confused, because they were unconscious and had no idea where they are, and they woke up suddenly. Not because I took away their high, but just simply because they came out of a dream and they have no idea what's going on, and their reaction is, oh, okay. So it can happen. I know it can. I'm just saying. It doesn't happen as often as it gets kind of portrayed. They can have, if you give them high doses, and that's why I'm not a super big fan of the 4 milligram, because the ones that we have now, the Southeast has given out, it's all or nothing. So you're giving them 4 milligrams. Well, we're taking everything away pretty quickly. So they can have a side effect of vomiting. In some cases, diarrhea can happen. So again, you had that? No? So for me, if this is working, I might just stick to this is working. Oh, the one that got diverted back again? That is, oh my gosh. For those of you at home, no, you don't want to know. All right. So, however, if you do need it, it's indicated and that's great, go ahead and add it into your mix. But much like other things, get your basics under control first. We've got good pulse, we've got good circulation, we're breathing for them, let's do this, great. Hey, CO2 pulse ox is looking pretty good. We're gonna breathe about once every 6 seconds for them, great. Color's looking good. All right, are we ready for that? Great, so let's give them a dose of Narcan. Be prepared for those kinds of things. They could be feisty, they could be combative, they could do those other things. My former boss, his concern, he also had that other idea of, and you may correct me, but there's something called, I guess, a speedball, where you do heroin or similar, and then you add in either cocaine or meth on top of it. So you're going speed up and slow down, because why would we want to do that? Because then we can stay in the middle again feeling all funky and really sharp. Okay. We take away the really funky, we leave nothing behind but the really fast, concerns for some tachyarrhythmias. So just things to think about. It's not as benign as it might seem. Well, it can't hurt. Well, yeah. Let's talk about in cardiac arrest. They're in cardiac arrest, and we think there's been a heroin overdose involved. Where does Narcan fit into this process? ABCs first. So, good high quality chest compressions, AED analyzed. If it's shockable, great, and do all of that. And we're still no shock advised, no shock advised. We can't feel a pulse. They're not breathing. They're looking like crap. Is Narcan going to help? Is it going to hurt? So the one little piece, so here's where it gets a little tricky, because if it's only an AED, you don't know if it's a PEA or asystole. PEA, there may be a pulse there, we just can't feel it. So it might help with that because we might get their respirations going, but I would still say it's probably unlikely that it's going to help, because it's not fixing the cardiac problem, it's only going to fix the breathing problem. And if we have a good airway with good chest rise with oxygen going in, and it isn't solving the problem, then Narcan isn't going to solve the reason that the heart stopped. In most cases, if we have what was an opioid overdose that went to a cardiac arrest, it was probably secondary to a respiratory arrest, and they just lost oxygen and they're done. The Narcan isn't going to fix and suddenly get the heart beating again. If we get it back, they're still not breathing, Narcan in there to help with the breathing piece, that might be appropriate. Just saying, certainly make it a consideration. It's in there somewhere, but focus on getting your CPR under control. Airway's in there, you got a good secure airway, we're getting ventilation, we're getting good numbers. When you buy your monitor, make sure it has end-tidal CO2, because that's a whole nother discussion. It's a phenomenal tool in all aspects of what we do. And you got that complete picture then added in. All right, so there are a number of drugs that are out on the street, and everybody's heard of all sorts of them. There's one that's out there, so everybody knows about fentanyl, heroin, all that other stuff. There's another one, and I cannot think of the absolute name of it, but the street name's Trank. You guys hear about this at all yet? It's a veterinary sedative. Okay. So it's carfentanil is in the same family as fentanyl, so it's another opioid synthetic. This one is a veterinary sedative that is not an opioid synthetic. It gives you a really good, it's sort of like that. Yeah. What they're seeing, at least out of the Rochester folks that we've been talking with, is it creates sores, and not just in the injection site, it can create sores all over the body. It's why it was never used for, authorized for human use. It's used in veterinary, but not in human. Thank you. Yep. So, but it can mimic and is being used to cut other opioid stuff. But if they're overdosing on that, again, ABCs are more important, because if we just go that and waiting for it to go, holy crap, well, it's not going to work. It never will work because it doesn't reverse it. That only reverses opioids, so morphine, oxy, heroin, fentanyl, Dilaudid, those are all in that family. All right. And then I'll just end with my little spiel, and I'll hand this out here in a second. But fentanyl is the most deadly, dangerous drug on the planet. Even looking at it will kill you, right?
That's what we've been told.
That's what you've been told. You guys especially, Department of DOJ has been putting out there how absolutely deadly this is, and you guys shouldn't be anywhere near it. If it were that deadly, dealers, public, family would all be dropping like flies. It is not. An incidental exposure to fentanyl will not hurt you. So if there was a pile of fentanyl over here, put my hand on it, shit. Wash my hands, I'm good. Even if I did it for 5 minutes, unless I have open sores, it's not gonna make a damn bit of difference. Well, it can go through the skin. If you have your skin prepped carefully, because the fentanyl patches that chronic cancer patients and those guys have, there's all sorts of chemicals in there that open up the pores to let it go in over days in very measured amounts. Really slow. It can be done transdermally, but it's extremely difficult. Now, if you take that same powder, jam it up your nose, put it in your eyes, yeah, you're probably gonna get a little buzz and you might actually have some trouble. If you throw a flashbang into a production lab as you're making entry and poof, and then go, okay, that could be bad. We don't go up and go, oh yeah, that's fentanyl. No, we don't do any of that. But if you're just wearing your gloves, if you're doing it, if you're doing a exactly. Yeah, why not? Ooh, this shift just got better. If you're just doing a traffic stop and somebody's got what you think's fentanyl, you don't have to take any super extra special precautions. Just don't have them thrown around. Don't let them eat the damn stuff. But if we're going into what you suspect is there's fentanyl even in the room, no big deal. Don't go knocking it over. Don't go sniffing it. You guys are wearing gloves on calls anyway. Big deal. Don't go rubbing or anything like that. It's not that big a deal. And that's not just John's opinion. This is the joint position on the American College of Medical Toxicology and Academy of Clinical Toxicology. So, and John's opinion. Exactly. But if you want, it's fun reading. And unfortunately, it's really actually been inhibiting our care that we're out there doing. And I'll pick on my cop in the room, but you guys have gotten a really bad rap on all that. There's been a number of high-profile cases throughout the country where law enforcement has been in what they think is a fentanyl situation. They end up going down, and then they end up getting Narcan and pop back all up. And I think it was San Diego. That sheriff made a big old press release, a big old plea that my deputies were nearly killed by this scourge of fentanyl. And it's not, not taking that away. Fentanyl is a big deal, and it's the counterfeit fentanyl because it's super easy to use, or super easy to produce, and it's being used into cut with heroin, which is harder to make and tougher to distribute. So great, we add a little fentanyl, which is super cheap to make. The cartels make it and ship it up, no big deal. We add it to the heroin, it hits hard real fast, then the heroin kind of seeps in behind it. So they get a real quick high, and then the heroin holds in afterward. They love it. But we've been talking about this, so the one in particular, very high profile, a bunch of news stories were out on it. The sheriff's doing this big old plea. But when you look at it, the poor deputy, he's on FTO, he comes on up and oh, it might be, and then you see him, he just tenses up, and down he goes. Oh, he's having an overdose, and they're bam, bam, they're hitting him with Narcan, Oh, well, he popped back up again. You could have sprayed beer up his nose, it would have done the same thing. It was an anxiety reaction because he was so conditioned that this was a deadly situation. It's not faking, it's a true manifestation. There's no shame in it whatsoever, but it is not as deadly as it is. If you're doing special operations, you're doing search warrants, be careful, but it is not that ultra deadly. The 1 grain can kill 12 million people. No, it can't. And it's really hurting our practice. We use it on the truck, and it's a really good drug. It's very, very controlled, very safe, and it's very effective. And I tell somebody, hey, have you ever had fentanyl? No, don't give me that stuff. And I have to talk through them for about 5 minutes. Well, Prince, it killed him. Yeah, because his supplier ended up buying counterfeit stuff and he had no idea what the actual dose was because it's coming as a counterfeit source. That's all. It's very good medicine. So don't be terrified of it. If you're going to somebody with a fentanyl overdose and you happen to see some laying next to the patient, don't get freaked out about it. Move the patient a little bit, just stay out of it. There's folks out here busting their ass doing this at almost no dollars, and it's that kind of care that they're getting. Your community is very lucky to have you. Go ahead and earn those jackets and license plates, and that's what you guys are doing. So I'm happy to keep coming if you guys need me, or when you want down the road, we'll figure something out. But and then on the other end of that would be, I just mentioned it to you, if you would like to see other places, so talk to Winona or talk to Mayo or Gunderson, or you can even give me a call if you want to venture over as far over as Dodge and do a ride along at someplace just a little busier or just a little different, just to see how somebody else does it. Nobody's got a complete corner or monopoly on how we do this stuff. What you will probably find is there's some more similarities than there are differences. Anybody watch Night Watch on A&E back in the day? You ever watch those guys? Dan and Titus, those guys? Or was that Dan? Yeah. You could jump on their crew and by the end of the shift, you'd be just fine. Yeah, their truck's laid out slightly different. Maybe they're using different monitors, but we're saying the same things. We're doing the same things. Tony Spector was the director for EMSRB for a while. Oh, if you've seen one ambulance service, you've seen one ambulance service. No, if you've seen one, you've seen most. We've got our 2 to 5% differences. We have some regional nuances, but we're doing the same damn thing. You could drop into a truck in Denver and I could go into Boston and we'd be running the same kind of calls. We'd be doing the same kind of stuff. So I'm really excited to be here. Thanks for having me. I'm done with that. Now I'll stick around as long as you want me. There you go. There you go. So,
Anything
yeah.
new
With the THC stuff, any interactions or?
Not really. One of our crews did have one that was one of our city festivals, and somebody they just said, well, one gummy isn't working, so they went to 3. And it was,
We've had a couple where the guy was like, oh, my heart is racing.
Yeah, I still think that was a bad group of stuff that came in, because we had like 3 of them
Yeah, it was
in
weird.
one
That's
week.
right,
Oh.
there was multiple of the same things.
And it was the same reaction, it was all, got it from a buddy.
I got it from a real trusted friend.
Yeah,
Well,
that's his name, huh?
yeah, and there are some synthetic stuff that's added. And that's the other piece, is maybe they did the hemp from the ditch hemp at once, and that's what their experience has been with the that much THC. Now they have a true controlled amount, and they maybe did a 10 instead of a 5 or whatever, and a little bit, ooh, this is new and exciting, and they're already almost having that anticipatory, this is going to be a freaky, and that could be as much of that too. But the one I saw was also up it was at the casino when I was working up there. We had a similar guy. He took like 3 or 4, and he's just going, hey Bob,
Yeah.
what?
Gosh, I'm talking
Dude.
to somebody like that on Thursday morning.
Dude, not much we can do about it. You just got to ride it out. Everything else was fine. So I haven't seen anything, and I'm curious where you guys are going to end up having to go from a law enforcement standpoint, because there's no standardized testing. So, however many DREs are out, but that's kind of a hard resource to find at this point. They could still fail a standard field sobriety even if they're super high, but it's a little tougher until they come up with a blood or breath that says we all agree that if you've got this much level, just like we do with alcohol. Because I've got a buddy that lives at a 0.1. So even though we say so he lives and is normal, he would be legally drunk to drive just because of the way we do it. Until we get that for THC, then it's going to be a mess for you guys. But no, we haven't seen too much. We just had 1 or 2 that were a little bit of that. So I'm sure we'll see a little bit more as it keeps going. But yeah, the regular users, they might have a little adjustment to some more standardized dosing, but that's about it. So anything else? Thank you. I really appreciate it. Good question.